So we have been at this for quite some time. The question of digital inclusion and exclusion has not just happened in the last 5 minutes. So ever since the first wave of the pandemic, we've been trying to listen to people about their experiences of trying to access care. And we have done an early publication in the summer that you can find on our website called The Doctor Will Zoom You Now. But maybe more importantly, we have been listening to our membership, and our members are obviously directly supporting people who are trying to live with ill health and disability and who try to access services. So we felt this merited a closer look because it became very clear to us from listening to our members and from listening to people living with ill health that this was a massive issue. We were witnessing a complete transformation of service models in primary care, but way beyond primary care. And we concluded that we needed to do some further looking and listening. And then the Accelerated Access Collaborative agreed that it was worth also looking at what our sector, the sector that we work in, charities, voluntary sector, social enterprises, are doing to help people overcome the effect of digital and other forms of exclusion. And this is what we're focusing on quite a lot today. But as we tend to do these days, we wanted our work to be very led by user voice. So if you go to the next slide, you can see some of the faces of the people we actually spoke to. Savannah, can you go to the next slide? So we did a literature review, and our friends at the Patient Experience Library helped us with that. That's shaping up to be a really useful partnership. And we worked with 2 partners, and you'll hear very briefly from them later on today as well. The Abbey Centre in the centre of Westminster, and the Centre for Seldom Heard Voices, who are in the southwest. And they spoke between them to just under 30 people who at face value seemed at risk of exclusion. And we asked them what they had experienced and also what their ideas were for overcoming this exclusion that they were experiencing and the problems that they were experiencing. And the takeaways, and that won't really surprise any of you who have been thinking about this or maybe working with people over the last 12 months, is that digital exclusion directly contributes to the inverse care law because it layers on top of existing inequalities. And I think Pfizer is going to talk briefly about this in a minute. It doesn't happen in a vacuum. It happens against the backdrop of language barriers, of poverty, of low literacy, of bad housing, of lack of trust in the state and its institutions. So it is not a value-neutral concept, digital inclusion and exclusion. It makes the inverse care law worse. That should give us pause for thought. The other thing that should give us pause for thought is that what we heard very clearly from listening to the people who described their difficulties is, if a service user says, I really need this for my care, and the service provider ignores that and says, well, we're going to deliver care like so, the outcome is very poor quality care. So if you flick through our report later, you can hear some of the testimonies of people who really were experiencing at times shockingly poor quality care. People were crying down the phone. They were unable to engage with what the service provider wanted them to do. They couldn't hear because they were deaf. They didn't have an interpreter, even though they said they needed one. If we worry about the lack of staff time, which I know is a massive problem in primary care and in the whole system, we don't have enough people to deliver the care we need, then we should really worry about the existing team and the existing workforce delivering care that adds so little value and that really doesn't shift on a problem that someone comes with at all. It is just a wasted appointment, and we should not engage in that. And worse than it being a wasted appointment, it further adds to people's expectation that they can't be held. Right, but we work in a creative sector. We're not happy with just admiring and describing the problems. So Sab, if you go to the next slide, we can see some of the organizations we've engaged with, and that's Kirit, who's one of our associates, who's contributed some of his work. And we asked then what are you doing? What has happened for you in the last 12 or so months? I mean, it's a bit more than that now, isn't it? And they started literally immediately innovating, and we learned so much from listening to our colleagues in our sector. And you hear in a minute from our colleagues who did a brilliant homelessness project in Leeds. Our members Groundswell were involved with that. And from all those innovations, and please flick through the report and have a look at them, and there is links in there where you can find more information. It is such an inspiring read. Here are the sort of keys to inclusive innovation as we see them. The innovations we describe are very rarely about some snazzy gadget. They are on the whole about being focused on inclusion, co-designing with the people whose needs you're trying to meet, supporting staff with changes, appreciating that health goes much wider than healthcare, and really leaning into the concept of personalization. What we are now taking away as a sort of policy outfit is, how do we need to think about inequality and personalization in a way that they begin to support each other? Because a lot of the exclusion people describe could have been prevented if frontline staff had been able to personalize their offer and had been able to say, we do it like this normally, but you're saying this doesn't work for you, and we believe you, and we're going to do it like this for you. And we think that is the kind of way of working we have to get into. We're also today launching a number of other outputs. So Savannah, if you go to the next page, we're launching some recommendations for better practice. You can find them in our sort of sister report to the one we're discussing today, called Call for Action. It's all on our website. There's some recommendations for better practice. There's some recommendations for better policy. Now, wouldn't that be good? Some recommendations for better innovations. And then, and I'm really pleased to reveal this here today, we are launching a poster that that you can print off and use as a leaflet or use as a poster. We print it off on A3. And it basically sets out in everyday accessible language to people themselves what they should be able to expect. Because we heard clearly that people go into their surgery or call their surgery expecting that there should be something, it should be possible to do something for them, but that they then are pushed back at times. And this is obviously not happening everywhere. And we know that GPs are working really hard, and that primary care in many places is doing its best. But we also heard about very inflexible, very unresponsive ways of organizing care. And this poster aims to equip people with the knowledge as to what they should be able to expect. And what's most wonderful is that this has been endorsed by many of our members, by our friends from Healthwatch, and really importantly by the Royal College of GPs and the Royal College of Physicians. So what are we doing next before I hand over to people who did this all in practice, because that's, I'm sure, what you're really most interested in. Let's have a quick look at next steps, Savannah. We are going, and we start today, share innovative practice. And you can look at the report we're publishing today, and it's got, the second half of it is full of great things our sector has done and what we can learn about what needs to happen to embed these partnerships and to make that a more mainstream way of working. Savannah, could you go to the next slide for me, please? We are working with system partners, and by that we mean a lot of national leaders who are tasked with thinking about personalizing care, about inequality, about primary care, about digital innovation, about how we need to simplify the communication around access. Many of you will have seen some really quite poor examples of communication on Twitter and elsewhere. We have a sense that, you know, there is obviously something we need to say to people about what access to care needs to look like, but that needs to be done in a way that feels compassionate, that feels welcoming, and that feels like easy to understand. So we need clarity of communication, but also kind communication. We want to share and distribute our patient-facing information, and we're hoping that we can get to a point where NHS England will also endorse our poster or a version thereof, that we can actually explain to people in very simple terms what they can expect if they want to access care. One idea we're very excited about is, and we're talking to HealthWatch about this, is that we think we need to engage with the non-clinical staff, for example, in primary care, the people who are what you in other industries might call the customer service people, and that we need to challenge and support them to understand their role in enabling access for people. And then finally, and I've mentioned that already, we think there's a piece of policy thinking to be done about how our thinking on inequalities and our thinking on personalization need to speak to each other. Right, I feel that I've talked far too much, and it's been a bit of a rush run through about 12 months worth of work. So we have time later to unpack this a bit and discuss it with the panel and with all of you. Do type your questions into the chat. I think for now, I'm going to hand over to our friends and colleagues from Leeds, who are going to talk in practical terms about what they actually did last year. Over to you.
Thank you. Can you hear me?
Very clearly.
Hi, I'm John Connolly. I'm Clinical Director at Bevan Healthcare. I'm a GP, and I'm very pleased to have this opportunity to talk to you about our Smart Health Inclusion Peer Advocates project. Bevan Healthcare is an inclusion health practice providing innovative health and wellbeing services to a population of more than 7,000 people across Leeds, Bradford and Hull. The inverse care law is very much alive for our patients. All of our patients are socially excluded, and many are digitally excluded for a variety of reasons. Their health outcomes are demonstrably worse in terms of life expectancy and complications of preventable illness compared to the rest of the population. Our patients include people experiencing homelessness and others in unstable accommodation, migrants in vulnerable circumstances, as well as those people seeking asylum, refugees, and those with no recourse to public funds. They include commercial sex workers. Many of our patients have both physical and mental health problems. Some also have drug and alcohol dependence, complicating their lives. The services we provide at Bevan Healthcare are tailored for the people we serve. They take into account their needs and priorities. And importantly, they understand that they sometimes need extra help to get the care that they need. When the pandemic first caused lockdown in spring 2020, it was very apparent to us that our patients and many thousands like them elsewhere would struggle massively with social distancing, with shielding from others, with getting food and medicine supplies, with the availability of illicit drugs and alcohol, and with switching to virtual or remote consulting in primary care. The doctor will Zoom you now is fine if you have a smartphone or a device and data and you know how to use them, but that's not the case for many of our patients. Next slide, please. The Everybody In policy gave us an opportunity to engage with people in new ways, and we tested digital platforms to work out how best to support people through this difficult time. We aim to keep in touch with them, monitor their welfare, and deliver seamless care. But we soon learned that providing laptops and health questionnaires was never going to be enough. The prototype, which was most promising, combined the technology offer with a trusted support worker who works closely with the individuals and helps them to access care. And this led us to collaborate with our partners at in the SHIPS project, including Groundswell, 100% Digital Leeds, and Helm. We decided to adopt the well-established Groundswell model of peer advocacy. My colleague Rachel Brennan will describe it in more detail in a minute. But basically, people with lived experience, but now in recovery, are recruited and trained to work closely with clients and help them develop skills and engage with services, including health services, but other services as well. We decided to make our peer advocates smart by equipping them with technology and training to address the digital exclusion which has made life so difficult for our patients during the pandemic. Our patients needed a friend, a buddy, a mentor, and crucially, someone that meets them regularly and that they can trust to support them and advocate for them with integrity, so that in future, they can live more independently and self-care for themselves more effectively. We decided that we would link our smart peer advocates tightly to the health and wellbeing team. Next slide, please. We asked them to promote
think we might have lost
Right, I
John.
think we might have lost John. I saw you sitting on the moor somewhere in his car. Just like, I'm always so jealous when I talk to someone in Leeds and they manage to get out of the city. But John brought a lot of really capable colleagues, so maybe one of your colleagues could take over.
I can pick up.
Super, thank you, Rachel.
I mean, I think John was on his last slide anyway, so I hope that I can seamlessly move into the next slide. So as John mentioned, it's very much a collaborative partnership project. I'm from Groundswell. I'm the Health Now Network coordinator. So just a bit of background about Groundswell for those who don't know. So we're a homeless organisation that primarily focus on health and health inequalities. And we really put people with lived experience at the heart of what we do. So some of the projects we work on are homeless health care advocacy, which I'll talk a bit about in a bit more detail, and also insight and action. So across the UK, we carry out research projects with volunteers that are trained peer researchers, so they have lived experience of homelessness themselves. Surrounding everything we do is progression. So for all of our volunteers and for our services, we're focused on how we can move people forward and move people out of homelessness, but also give them the opportunity to participate in solutions. The project I work on, which is Health Now, really takes the services that Groundswell have been developing, over the last sort of 10 to 15 years, and work with organisations in local areas to help them adapt our models, learn from our best practice, and really sort of just make sure that they're able to do meaningful participation and involvement of people with lived experience. And then it's capturing all of that. So I think very much with this project, we're not just, capacity building from our experience with Bevan Healthcare, but we're learning from each other. And we've also created a network. So we've got peers that are working on health inclusion projects across the UK who all get the opportunity to come together, share their practice, learn from each other and network. Within Groundswell, 2/3 of our staff have personal experience of homelessness as well, so it really is the centre of everything that we do. The next slide, please. So as John says, the SHIPS model is taking part of the homeless health peer advocacy model that we've developed and been delivering in London for the last 10 years. And essentially, the project is taking people with lived experience of homelessness and giving them really comprehensive training. So we do advocacy training, safeguarding, boundaries, risk, mental health, first aid, drug and alcohol. We keep adding and adding to it. And it's a volunteering opportunity that essentially means that people who have experience of homelessness are supporting people who are currently homeless to navigate the healthcare system and access the healthcare that they need when they need it. It's really built on relationships. So it's identifying that part of the barriers for people who are homeless in accessing the health services are based on trust. And that's what we try to build. We believe that when people have a shared experience and when people are volunteering as well, it's really powerful, and that they develop trusting relationships with people. And they have that shared understanding. They speak the same language, and also they provide a really positive role model for people. What we often hear is that they're supporting clients who feel like they're at rock bottom and they've been there, but they've come out of it, and they can share that experience with the people that they're supporting. Throughout the work that we do, there's a real focus on developing independence. So it's not just about enabling and doing too, but it's supporting people to be able to get to the point where they can independently access the healthcare that they need and self-advocate. And I think that's really important for the work that we've been doing on digital inclusion, and that Amy will talk a little bit about, and how we're supporting people to be able to access not just health services, but also a variety of services through digital platforms. And what we found from evaluations that we've done and from our stakeholders is that really homeless health care advocacy benefits the clients because they're accessing the healthcare that they need when they need it, and they're being supported to be able to independently access, which is a benefit to their health. It supports the peers because what they get from volunteering and supporting other people, plus all of the progression support that we give to people. So every month we're reviewing where the volunteers are, where they want to be. We invest in training. Our aim is that within 12 to 18 months, 70% of our volunteers go on into education, employment or training. And actually, we heard just yesterday that one of our volunteers on our Bevan project has already, built the confidence to go on. They're leaving already to go and do a training program, which is really exciting news. But also the health service benefits. So, some of the challenges of not being able to access the right healthcare or any healthcare have a massive impact on the longer term impacts of the health service. And what we know is that if people don't access the healthcare they need when they need it, they're more likely to access in emergency situations where the health has rapidly deteriorated and it takes much longer and is more costly for them to recover. And then I'm going to pass on to my colleague Amy.
Thank you, Rachel. So my name's Amy Hearn and I'm a Digital Inclusion Coordinator with the 100% Digital Leeds team. So that's a small team within Leeds City Council that's working to make Leeds the most digitally inclusive city. So next slide, please. There we go. So there we are. That's my team. So you can see that we're only a small team, and certainly at the start of the pandemic, we estimated that there was somewhere between 50 and 90,000 adults in Leeds that were low or no internet users. So with that in mind, our approach is to work with the organisations and departments and groups from all sectors that are already engaging with those communities and individuals that are more likely to be digitally excluded. And our role is to facilitate and support them and work with them to co-design interventions that are mutually beneficial for the organisation and for the individuals they support and for the city. So that's a asset-based approach. So in order to make it sustainable and ongoing, we want to build upon the work and opportunities that's already happening and already taking place by each of those organisations, taking advantage of and building upon their knowledge of the needs and barriers that their service users are facing that are usually very complex and differing from community to community and from person to person. And also utilising those strong, trusting relationships that those agencies and organisations have with their service users. So with that in mind, we can build a variety of interventions that take place across the city that are all focused on a person-centred approach, where organisations have a range of options available to them that they can support the individuals that they work with. Next slide, please. So when we were asked to partner with Bevan and Groundswell, we're really delighted because the peer advocacy approach and Bevan's person-centred approach really resonates with us, and it follows exactly the kind of path that we would ideally follow with an organisation anyway. So they already had a really great foundation to work with. What we've been able to do is build upon that already brilliant infrastructure to just add some digital inclusion specific support elements within to make sure that those beneficiaries that are able to get support from the peer advocates are also able to be supported within with digital, and also that the peer advocates themselves and the staff around them knew how to use digital and the right approaches to take and all of that kind of stuff as well. So as I say, we use a strengths-based collaborative approach, so looking at what are the opportunities within what's already set up for people to have positive conversations about digital, encouraging conversations about digital, understand the different barriers the people that they're working with face and to what level, because we recognise that everybody's on their own digital inclusion journey. Everybody is starting from a different point and everybody has different things that are stopping them from being digitally included. For some people, it might be something as simple as just being able to have access to equipment. For some people, it might be really, really deeply ingrained negative attitudes towards digital, to their idea of themselves being a digital person, and their confidence in their own abilities to engage with digital. for some, it just might be a complete lack of engagement and lack of understanding as to why they even ought to be engaging with digital. And so that leads to a really complex a really complex situation with lots of different variables that needs a person-centered approach, really focusing on the individual's barriers, the individual's motivations, and what they would benefit from, the support that they would benefit from, and also recognizing that each individual is on their own digital inclusion journey. So for something, we might think we understand what would benefit a person. So say being able to use a digital tool to be able to do a virtual consultation. And although that would benefit the person, often if they've got those really complex thoughts and feelings towards their ability to engage with digital and what that means, those benefits that we understand might not be enough of a motivator for the individual. So we were really thrilled to be able to build on this peer advocacy approach where the advocates already, because of their lived experience, were able to partially understand some of the context and the barriers that the person was likely to be facing, but then they also have an ongoing relationship where they get to further understand the particular complex situation that the person's in and take time to support them along their digital inclusion journey. So in terms of data and access, we recognise straight away that for a lot of the people that Bevan work with that are already excluded, having connectivity in terms of the correct device and reliable Wi-Fi or data was a massive problem. So we've been able to work with multiple different partners to identify donated equipment in terms of tablets and phones with data provided, so that anyone that needs it is supported to have equipment over a period of time that's theirs to keep and use in whatever way they would like. The digital champions themselves have all received training in digital awareness and had their own skills levels assessed and supported to be developed to a certain level, and also awareness of the different tools and resources they can use to further upskill themselves. Their digital skills and needs are part of an initial needs assessment that the person's taken through when they join the peer advocacy scheme. Each of those also had digital champions training so that they understand all the things that I've just been saying about the person's end point. The end goal might not be the thing that gets them to start engaging with digital, and we need to think about really personal reasons and what would they like to see that would be a bit of instant gratification in terms of, you know, how they live their life, but also the idea of understanding that for a lot of people digital is and people can really lack in confidence in their own abilities. So different things that we recommend, such as pairing the known with the unknown and finding things that people can do digitally that will also allow them to feel within their comfort zone and recognise that they have a sort of ability. So all of that. And then in terms of wraparound support, we've also been working with different organisations. So not only is the person able to get support from Bevan and the peer advocacy scheme, but also recognising that there will be other agencies and organisations around that person, different organisations that support refugees and asylum seekers and other and vulnerable migrants, different organisations that support homeless communities, sex workers, etc. So 100% Digital Leads is working with each of those different organisations to embed similarly as a similar approach digital inclusion throughout that their work, so that everywhere that every touch point that those people have with different organisations, everyone is coming from the same viewpoint, everyone understands digital exclusion, what the person's needs are, and can encourage them to do more and be more motivated. Next slide, please. So finally, I just wanted to show, so it's taken a long time to be able to get this approach up and going and get it right and recruit the volunteers, and they've had an intensive amount of training. But as Rachel said, already we've been seeing some of those benefits. And these are a few quotes. I'm not going to read them out because I know that I've spoken for too long, but service users are already, you know, absolutely thrilled by being able to access devices and being able to access the health tools and the other things that are important to them, such as staying in touch with their family with those devices. And in terms of advocates, we can already see that their confidence and skill level and confidence in their own abilities to learn and do things like this has meant that they are taking steps to further improve their situation, as Rachel said, by doing things like going back into education, which is absolutely amazing. So thank you. I'm just going to hand over to Daniel to just finish off and talk about Helm and how that's going to fit in with the future plans for the project.
Daniel, you've got about 1 minute.
Okay, no worries.
So keep it really short, thank you.
Yes, certainly. Good morning, my name is Daniel Hardy. I work in Leeds City Council. I'm part of what's called the City Digital Partnerships team, which
Can you go to the next slide?
Which is a partnership between the CCG and Leeds City Council itself. I'm currently managing a project called Helm, which is a person-held record. So it's an electronic person-held record that allows people to view their health record, but also add notes, comments, and readings from home devices such as blood pressure monitors, so they can be viewed by their doctor. It was developed in Leeds. We had a lot of user input on what it should look like, what it should do, and that's something we'll continue to do as we look to add functionality. The idea of having something like this is part of what we call the left shift, and that's about trying to increase people's involvement and activation within their health, their own personal care, and trying to get people more involved so that they understand their conditions better, can recognise when they might be experiencing symptoms, take action earlier, but also make informed choices about their lifestyles to help them. One of the key things that sorry, next slide, please. So this is what it actually looks like. This is my Helm record. One of the things one of the sections that we have, which is not on this one, but actually is on another page, is something called What Matters to Me. And what matters to me is a series of questions that asks people things like, who are the important people in your life? What do you do to keep yourself well? Please do, please don't. And these responses can be viewed across a number of health and care settings, which means that citizens can receive consistent care and make sure that health and care professionals are taking notice of their wishes. In the SHIPS process, what we want to use is use this functionality to enable people who are suffering from homelessness, once their training is level, their confidence levels are correct, to start inputting information that can then be viewed by the health and care professionals back at Bevan to understand how they're getting on, where they might be struggling with both their health and their well-being, and ultimately use that two-way communication to send out information, suggest people come in for a conversation, all those kind of things. So it's trying to give them the skills to use this digitally and then use it to make a more regular contact to keep people informed of what's happening, keep health and care professionals informed of how people are getting on and where they might be having issues, and then deal with those issues sooner. This sort of two-way thing, as I say, means we can push information out to people. That was very whistle-stop, but hopefully you got what you needed from it. If anybody wants to ask me any questions, please feel free. Thank you very much.
Thank you so much. And I think if you look at our report, this is just one of the brilliant examples of collaborations for inclusion. And what really jumps out at me is that this really straddles the statutory and the community sector, and that it straddles formal and informal support. And I think a lot of our examples share that characteristic. This is what we will need. And that's what we've learned from the vaccination program, is that no matter how wonderful the statutory provision is, it can't reach certain people if it doesn't straddle into the informal support and into community outreach. There were a couple of questions, and I'll ask you for very short answers because we want to move on with our panel discussion. Someone said, are you doing any work? I think Faiza asked, are you doing any work in this project to sort of include people who don't speak English as a first language? Have you thought through interpretation and that sort of stuff? And then someone else asked, are your peers staff or volunteers? Which I think is an important question. And then Daniel, one question for you. How does is this similar to Patient Knows Best? I don't know whether you are aware of that. So Daniel, shall we start with you very briefly?
Yes, it is similar in essence to Patient Knows Best, and I know that has gained some traction in other areas. The big difference is it's owned and the IP is owned by Leeds Council, so it's not a private sector application.
Solution, yeah. All right. Rachel, do you want to deal with the language and the peer quest?
Yeah, I can take the other points. Now I realised we probably got cut off at the point that John was going to give the update, and my mind had just gone blank when that happened. So far we've recruited and trained peers in Bradford, and because Bevan Healthcare are a homeless and inclusion health practice, there's very much been a focus on sort of the migrant health and support for people who are newly arrived. So I think out of our 15 volunteers that progressed through the training programme, 75% of those have different languages, because they've also gone through the refugee and asylum seeker process. We're just about to do our recruitment in Leeds, where we're going to have more of a focus on people with lived experience of homelessness. But the idea is that we would have, it would be mixed going forward, and we've had some really good support from a public health professional on that as well. So making sure that we're taking more time and that people understand. But we've, like Amy said, we've had some really positive feedback. I think the other question, which I have replied to, is about how we've been recruiting the volunteers, and a lot of that is because Bevan Healthcare is such an established organisation that do, a lot of collaborative and multidisciplinary work across Bradford, Leeds and Hull. So we've been able to maximise stakeholder engagement, and it's been really supported by the CCG as well. So a lot of our volunteers have come through that, but also a lot of the volunteers are Bevan patients as well. So working with the social prescribing team, they've managed to identify volunteers really where this opportunity is appropriate for them at the moment.
Okay, thank you. Very interesting example, really inspiring. And the people we've got on the webinar who are on the whole engagement practitioners, I'm sure going to be able to take a lot away from this example. I know a couple of you have their hands up. I don't think we've got time to do verbal questions, so please type them in the chat if that's possible, and we will try to get them onto the panel. Faiza is one of the people we have on the panel, and she will very briefly talk about what the Abbey Community Association actually did for us. Faiza, over to you.
Good morning, everyone. Can you hear me?
Yes.
Hi. Yeah, hi everyone. Thank you very much for having me today. We are so excited to be part of this interesting piece of work, and it was a big opportunity for us, to be honest, to involve and to interview 15 people from our people. Just a brief introduction about the Abbey Centre. We are a charity in Westminster in London. Our vision to see healthy and cohesive communities in South Westminster by bringing people together, an organization to address community needs. We do this through a range of services and programs aimed at improving the health and well-being of people experiencing low income or unemployment, tackling the health inequalities of ethnic minorities communities, and addressing the health impact of social isolation on vulnerable older people. In addition, we manage a thriving community hub and community network, provide volunteering opportunities, and improving inter-community and intergeneration engagement and understanding. Since 1948, the charity is supporting the community, and we are working directly with just under 6,000 clients. Next slide, please. We have the honor to participate in this Unlocking the Digital Front Doors, and we funded by National Voices. We interviewed 15 participants from the most disadvantaged BAME community with high burden of ill health and who are affected by inequality. Through our listening exercise, we explore people's experience and barrier to healthcare services. Participants share many examples, including struggle with online prayer form and frustration with not being given appointment times. I just got some code from participant here to share with you. I couldn't complete an online form. I couldn't do it. I wouldn't know how to access the apps in the first place, or how to put an app on iPad. I wouldn't know where to start. I seem to get in a muddle. But if I had to do something out of the ordinary, access fill in an online form, I wouldn't be able to do it. When I phone to speak to a GB, receptionist asks, what is the reason? And she explained. Then she says, the doctor will call you back. I don't know when the GB will call back. Later, when the doctor phone call, some of the things I forget. I can't explain properly. It is very difficult. I couldn't use a computer, never had a smartphone, didn't know how to use one. It hurt your head. At first, believe me, it hurt. If you are not used to it, it hurts your head. Next slide, please. In regard to the skill, access, and poverty, I got some quote from participants as well. I hope they do not introduce this type of services, virtual healthcare in the UK, especially for people like me, whose English is not their first language. But if there is no choice, maybe to have interpreter and smartphone, free data and good Wi-Fi will help. It is difficult because of my husband has a lot of problem and he needs support. He needs someone to help him to just walk, but they told us, no, it is not allowed. And it is just one person because of the situation. But sometimes people don't understand what I am saying because of my speaking problem. Over the phone, make it worse. I got more nervous and shut up. I have got an advocate. I have one at the moment because of COVID-19. They just talk to me online, not face to face. It is like putting a plaster on a giant cut. It doesn't cover everything I need. Next slide, please. Poorly executed remote care impact on experience and quality of care. Got some quote from participant. I had a telephone appointment with a physiotherapy for my hand. It was very difficult and I couldn't understand what she was saying. My hand was in pain, therefore I couldn't focus on what she was saying. Also, the physiotherapist didn't see me. She kept telling me, do this, do that with your hand. If she saw me, she would have realized that I was in severe pain. Digital healthcare models are very stressful for me. They enhance my anxiety. Digital healthcare put me off accessing services because I want somebody to talk to me face to face. A doctor that can treat me like a human being. Next slide, please. In conclusion, more digital solution and invention are not the answer for everyone. And providing choice and support is critical. Thank you very much.
Thank you so much, Liza. Thank you for bringing to life what you've heard in your work. A very brief message to our BSL interpreter. I appreciate that you would have normally had someone else working with you to give you a break. I don't know what's happened. We seem to have difficulty getting them on to the call. Sam, who's in the background, is still trying. So if you could just bear with us, I'm really sorry. And you know, we will need to talk afterwards about how this happened. Okay, and now I'm going to hand over to Mel from Bournemouth, who will hopefully in very brief time, because we want to have some time for discussion, tell us what they've done and heard.
Yeah, absolutely. Thank you. Very similarly, we were kind of tasked with gaining some insight into what the experience of digital access had been for people. And we came across some very similar experiences around access to technology and being able to use it. But actually, I'm just going to pull out a couple of examples of what really struck us in addition to that, which was about quality of care and impact on quality of life. So we had quite a few experiences where digital access was actually creating a dependency which hadn't otherwise existed for people that we spoke with. So, for example, we spoke to someone called Angela who's profoundly deaf, and she explained that she can't use her hearing loop on modern mobile phones. There's no jack to plug it into. So she's now having to rely on her husband to translate on the phone between her and health practitioners, which has completely affected her sense of independence as somebody that normally engages independently. As she said, it's personal and my health is my business. A lot of the people we spoke to talked about the impact on their privacy. Having to send photos was a massive concern for people, the responsibility of taking a photo and knowing that it was right, but also being concerned about what happened to that photo, who would see it. And fears of being overheard was a big issue. So we spoke to someone called Lisa, who's visually impaired, has a history of domestic abuse. She talked about having to wait for the GP to call back in that 4-hour window, and then having to take the call at work or while she was on the bus. So she talked about issues of privacy, but also of risk of actually not being able to talk about things openly, and so not mentioning things that she needed to mention, and concerned that other people would be doing that too. And finally, another headline that we wanted to flag up today was how many people we spoke to that talked about not feeling valued or listened to because of the lack of choice and flexibility about how they were engaging with healthcare professionals, and actually that they were avoiding contact as a result. So an example was Josephine, who's in her 80s, cares for her husband who had a heart bypass and has recently been diagnosed with dementia. And she talked about just those frustrations of sitting on a phone, waiting for a long time for it to be answered, e-consultations not being responded to. She said she's now not contacting the surgery as much as she'd done before. She said, you've got to phone up, you might get a response, you might not. So she talked about how she now waits, decides if something gets worse, will it go away on its own before she makes contact. So Angela wanted the option of having face-to-face contact where she could communicate fully. Lisa wanted set appointment time so she could ensure she was in private space. Josephine wanted to know that she could just contact someone and would be listened to. So lots of the themes that have come up already, but it was about really good responses were ones that recognised all of these complexities and offered choice, control and flexibility.
Thank you so much, Mel. And yes, having read all the narratives, all the stories that you can read on our website now as well, it's really struck me how abandoned some people have felt and how neglected some people have felt, and how that will also undermine trust and a good relationship between service providers and patients. We are slightly overrunning, and I'm really sorry about that. That's probably my bad chairing. So we are really pleased to have Kieran here, Kieran Collinson, who is a GP and from Oxfordshire, but also leads on inequalities at NHS England for the primary care team. And therefore is quite close to those people and processes and systems that could address some of what we've heard today, but also, you know, works every week as a GP, so probably has practical insight to share. Kieran, what have you heard, and how does that land with you?
Yeah, well, thank you, Charlotte, and thank you everyone for having me here. Yeah, so as Charlotte said, so I'm a GP. I'm based in Oxfordshire, and I'm also in the primary care team at NHS England and Improvement. And I mean, everything I've heard today, I think it really resonates. Really interesting actually to hear all those reflections. And I think it's something that we've all become more aware of as time has gone on. And a year ago, when we jumped into action using lots of digital approaches, I mean, it felt like the right thing at the time, given that we were at the beginning of a pandemic and trying to keep safe both staff and patients by doing as much as we possibly could over the phone and online. And, you know, that did feel like the right thing to do. And actually, it probably still is, you know, when we look back at it in hindsight, I still think that was the right thing to do. But we've clearly learned a lot over the course of the last year. And I think what's becoming more and more apparent is that it does work really well for many people. And I know, so I was in the surgery on Monday, and the number of people who phoned from work and could get a consultation over the phone could be managed effectively. It was good for them. It was good for me because I could do it over the phone quite simply. You know, it worked really well. But there are some where it really doesn't. And that is the thing that is becoming more apparent now. And I'm so glad you're doing this. And I'm so glad you've released your report as well, because it really brings home the inequalities that we've seen in many ways over the course of the year, but not just the year, for decades, in fact. And as you said, Charlotte, I work in the inequalities team as well. And so I feel very strongly that we need to have opportunity for everyone. And so when it comes to us looking at how we do that in practices, and for example, in my own practice, it really is about that personalised approach. And for many online digital will be absolutely the right thing, and we should encourage that if people want that and it's good access for them and they get the care that they need, but also acknowledge that it's a fine balance. And some people won't be able to do it over the phone, as we've just been hearing this morning. And I've, certainly in my own practice, we're very sensitive to that and becoming more aware that we need to be even more sensitive to that. So I spoke to a patient on Monday and tried to get the story from him over the phone. And it was a bit disjointed. He couldn't quite communicate it clearly. I didn't quite know what he was getting at. And in the end, I said, how about I see you? Booked him in for a couple of hours later. He came down and I saw him. And it was a very fluid kind of approach. It wasn't going to happen online. That's absolutely fine. So let's do it in person. And that was going to be best for him. And I think overall, it has to be that personalised approach. What will work for that individual and what will work for one may not work for another. And so it's ensuring that we constantly have that type of discussion with people so that we know what is best for each person.
Okay, thank you so much, Kieran. And yes, I think that is a theme that really comes out of our insight, is that you need systems and processes, and you need to build these as inclusively as you can, obviously, and as accessibly as you can, but you also need to have the flexibility and the wherewithal to adapt to the person in front of you. And I think many of you are obviously trying to do that, if not most of you, or even all of you. But we have just unfortunately heard of people who felt very locked out. And I think that we need to address that quite urgently, because it contributes, as we said, to the inverse care law. And if Emily Lawson had been here, and I'm so sorry she hasn't, I was really looking forward to being in her limelight. I mean, what a hero of this pandemic. She would have also, I think, emphasized that this connection between personalization and consistency was really important to get the vaccine out to people who otherwise would have not benefited. I'm afraid this is probably all we have time for. There have been some technical challenges, and we will do a wash-up and review those. And maybe this is indicative of us all still learning how to live in this new world. Having said that, if this had been a physical event, many of you would have not been able to come. So I think that kind of is in a microcosm what we're dealing with. This makes it possible for people to engage. We live in Leeds and might not be able to come down for the whole day, but it also locks some people out, especially if you don't do it right. And I think there's been something wrong in the background, because we had a load more people sign up to this event than in the end were able to attend, for which I am so sorry. We will make this recording available. We will send the link out to everyone who registered. We will make all the material available right now. It's on our website, the reports, the call for action, the insight that Pfizer and Mel described, and all those brilliant innovations that you can take away. I don't know how many of you are actually engagement practitioners, but I think if you zoom right out, then what we're taking away from this is that we will only overcome digital exclusion by engaging properly with the people whose needs we meet. And you are obviously so central to that. So muscle to your elbow and have a good rest of your conference. I know there's so much other good stuff coming on. That's it from me, but Alice, I think, wants to have a very quick last word about your assessment of this webinar. Alice, over to you.
Thank you so much, Charlotte, and thank you to all of our speakers and all of the participants who contributed so fully on the chat today. Once again, apologies for some technical difficulties, and Emily has certainly sent an email saying that she did very much want to be here, so we'll investigate those. But just as you leave, it would be really helpful for us to get a bit of a one-word comment from you in the chat, how you found today's webinar. Was it informative? Is it useful? Would you have preferred more of something or less of something? In good engagement practitioner style, do give us a bit of a note about what worked well and if we can improve anything. So thank you so much for being here today. We really appreciate it, speakers and attendees both. Thank you.